Right then, well, welcome everyone. We are here in another week of Joint School Live, and today we are very thrilled and honoured to be joined by none other than Professor David Barrett, who will take us through a masterclass of knee replacement surgery. So, thanks very much for joining us.
It's a pleasure, Axel. Nice to be with you.
An absolute pleasure. Now, before we dig into the questions that many of you out there have so kindly sent in to us and suggested, what would you say to introduce yourself to our audience?
Okay, well, I'm a professor of biomedical engineering, orthopaedic engineering, and I'm a consultant orthopaedic surgeon with a specialisation in knee surgery. So all I do is knee replacement, knee surgery, knee reconstructions. And so, if you like, knees are us. That's all I do.
That seems very appropriate. Now, but yeah, again, I guess so. We often start with a bit of a sort of personal angle about you, the surgeon, and how you ended up where you are. And
okay.
so yeah. Well, why is it you became a knee surgeon?
Well, I've always enjoyed surgery, so I chose that specialty after going to medical school. And orthopedic surgery was particularly appealing to me because you could fix stuff. And I really liked fixing stuff because once you fix stuff, it remains fixed and people get a very obvious and genuine benefit from your intervention. So orthopedic surgery as a whole attracted me. And then as I went through orthopedic surgery, it became clear that I like knee surgery. Knee surgery is technically quite complex. The knee itself is one of the more complex joints that we've got in the body. And so the knee surgery is a great mix of medicine and art, but also science. And so my other interest was engineering. And like I said, I was a professor, I am a professor of orthopedic bioengineering, which means that we link the two things, the art and the science together. So I design implants, that's part of the engineering thing, and I also put them in. And so it's a perfect balance for me. So knee surgery was what I chose to do. It is technically quite demanding, but it's great fun and it's immensely rewarding.
That sounds very appealing. And in terms of knee replacement surgery itself, which part of the procedure would you say is most satisfying?
That's a great question. I enjoy operating. That may sound funny, but it's technically very satisfying to be able to address a damaged knee and make it right. And there's a part of the knee surgery where after you've done all the operation, you put the implant in. And then you almost trial the implant. That means you move the patient's knee and you make sure the implant is in the right place, it's doing the right job. And sometimes you can have a patient's knee that doesn't bend very well or it's at the wrong angle. And so your surgery has been to correct that angle and make the knee bend a bit more. And it's the first time you actually see how that works out. And so that, for me, is the best bit, that if you've executed your plan and the patient's knee works, then it's a great feeling. It's a very satisfactory feeling as part of the knee surgery. So that's my best bit, if you like.
Oh, yeah, fantastic. Well, I guess many people may be able to sort of recognize that feeling from a bit of DIY or carpentry or something like that. Although, you know.
Right. That's something more difficult, I'm sure.
Indeed. Now, well, let's start moving slightly more technically. Now, there's some terminology to address because I know, many people will have come across the term knee replacement, but there's also the term knee resurfacing, which
Sure.
is sometimes used to mean a few different things.
That's a really great question, and it's a question that often the patients ask me. And really, what we're trying to do is explain to patients now how things have changed in knee replacement surgery. So technically, they're all types of knee replacement, but patients perhaps in their 60s or 70s will be able to remember their own parents having knee replacements, and they might remember some of the horror stories or some of the concerns about surgery. And so a while ago, knee replacements were simple metal hinges, rather like door hinges. It was a big operation. It wasn't very pleasant. There was a lot of rehabilitation, quite uncomfortable. And so what we're trying to explain now, that knee replacement has changed a little bit and evolved to a resurfacing technology. So rather than cut the whole knee out and put a metal hinge in, what we're trying now is to resurface the existing joint itself, which means we can leave more ligaments and more natural tissue. And patients might be more familiar with the concept of hip resurfacing that Andy Murray had, the tennis player. So obviously we can cut the whole hip joint out, or we can resurface it. And obviously as a younger, more active guy, he wanted a hip resurfacing. So in many ways, that's how knee surgery has evolved. And although they're all technically knee replacements, I call them knee resurfacings because we're trying to explain to patients this is not what their mum and dad had. And then in the more cutting edge of how we're developing partial resurfacings. And for me, that's the really interesting issue, because what we can do now is partially resurface the knee, which of course leaves even more of the natural tissue, which means the recovery is quicker, the activity of the patient is much better afterwards, and we can operate on younger people who have early joint disease.
Interesting. And so in some ways, the terminology there of knee replacement to knee resurfacing is a reflection of how much really things have changed and improved really for patients.
Correct. And what we've always tried to do is try and improve our activity. And this is some of the work that I've been involved in the engineering studies, is trying to develop a lot more patient-friendly knee. So if you like, in the old days, you waited till as long as possible before you had your knee surgery because it was such a big operation that you really would wait a very long time. What we're trying to express to people now is because we have a number of, if you like, more nuanced options. So we have a number of options what to do with people's knees, that it's better to see people a little earlier before they give up the ability to walk, so we can actually offer them more options. And partial resurfacing is part of what we'd offer them earlier than, say, total resurfacing or the old-fashioned total knee replacement.
Yeah, interesting. And of course, doing it earlier might mean that you can maintain more muscle bulk, more movement, and get access to things.
That's right. So if you like, it's a bit like going to a dentist earlier on, having a tooth filled, rather than waiting for years and having all your teeth taken out and having a set of false teeth. I mean, false teeth work, but obviously you would prefer not to have them if you could avoid it, and have a filling instead. So this is very much operating at the filling edge or filling end of the spectrum.
Yeah, interesting. So it's clear that things have changed a fair amount in recent decades in terms of knee surgery for severe knee arthritis. If you had to pick one thing, what would you say has been the most significant change in your career as an orthopedic surgeon?
Well, so I'm going to cheat. I'm going to say two things. Okay.
Yeah, I'll allow that.
Yeah. So the one thing is our new designs. So and I've touched on that already. So but essentially, partial resurfacing has made a huge difference to how we can keep people active, keep them playing tennis, skiing, riding horses, and for many people, you wouldn't know they've had anything done. The recovery is 3 times quicker, and although the operation is technically more demanding of the surgeon, so they're slightly more difficult to do, and they're only done by specialist knee surgeons, frankly, we're seeing a huge improvement in patient outcome. The second thing, which probably is more interesting to patients, is actually we've changed how we look after people after knee surgery, and we've changed how we rehabilitate them. So in the old days, it was just a wall of pain, and it took a year to get better after the operation. And people will have heard stories from their parents about how awful it is. Nowadays, we're looking at a couple of days in hospital, walking on the same day as the operation, and pretty much by 6 weeks, most people would look at the patient and say, well, look, I think they're better. So the pain management, physiotherapy, rehabilitation, sort of an attitude where we make the patients think very positively about their operation has changed a lot. So I think that's the second big improvement we've seen, which is giving us better results.
And hopefully very encouraging to hear for those who are watching this, sort of gearing up, so to speak, for the operation itself.
That's right. And I think sometimes the worst thing about people saying they're going to undergo a procedure is someone always knows a friend that's had it, that all went wrong and it was terribly painful, and they wish they never had it done. And so really, this is just to countenance those stories that it's not all like that, and there has been a huge change in how we approach this, and certainly those of us with specialist knee surgery practices would have a very tight control on how people felt after the operation. We're making sure that everyone has appropriate painkillers and rehabilitation, they get out of bed and get home, really.
Yeah. Okay. And so, speaking of change now, and without digging into this too much, because I think we could do a whole separate session on on the impact of COVID-19 on knee surgery. But of course, everything in a way has changed in recent months. In general terms, how would you say, now that we're seeing a return to surgery, how is the experience for your patients now in the current circumstances different from what it was, or what new things might they need to expect?
Sure. I think that the change is in the preoperative period. And so I think as soon as the patients get to theatre, then and they're under our control, their rehabilitation and their recovery is exactly the same as it was pre-COVID. I think what they'll notice is the workup or the preparation for the operation is a lot more detailed, because we have to make sure they're COVID-free. So no one in the UK will get an operation if they have a COVID positive swab. And so the plan right now, and it's changing, it even changed this week actually, is that if you're planning to have surgery, if you have a date of surgery, they ask you to be very careful, but not self-isolate necessarily for 14 days beforehand. Then 3 days before your operation, you have your COVID swab. And those results have to be with the hospital before you can get your surgery. After your COVID swab, then you self-isolate for 3 days and then come straight to the hospital and have the operation. So that way we can ensure that everyone's COVID-free when they come into the hospital. And all the hospital staff have COVID swabs as well to make sure that we're free of infection. So it's the workup that is a little bit more complex, what we call the workup. The preparation is a little more complex for the surgeon, for the patients now, but the surgery is just the same, and their rehab will be just the same.
And of course, I think it's probably worth flagging that as this video will be out on YouTube, and you watching this now, you may well be watching this sometime into the future where recommendations may well have changed. And so, as ever, and as we always say, it's always about following the plan that you as a patient have been given from your surgeon and your team. That's
right. And there will be some patients who are deemed high risk, and they will be asked to self-isolate for 2 weeks before their operation by their surgeon. So absolutely, the care is individual. This is just a general picture this week. And if you'd asked me last week, I would have said something different. So stick with the game plan. Your own surgeon will give you your own specific advice.
Yeah. And I guess then leading into the next question, which we can't, where we can't speak specifically, but it's a commonly raised question through the Joint School app and on online forums and questions that we get sent in, and as ever, please do keep sending the questions, and we will raise them in interviews like this. But a very, very commonly asked question: how do I know that now's the time for me to have my knee replacement?
Okay, so that is a really, really good question. And in the old days, it was when you couldn't walk anymore. And that's really simple, because the surgeon would say, look, it's such a major operation. You really want to know you have it. So you go away now and come back to me when you can't walk or you can't go upstairs. And people will still say that, and we're perhaps anxious to give a message that perhaps that is old school now. And what we're talking about is levels of pain that interfere with the quality of your life. So that means if you're having difficulty sleeping, if it's difficult to get up and down stairs, if you're restricting your activities because you can't walk as far as everyone else. So a good example would be that people might take the car to get to the shops because they can't walk to the shops anymore. But then when they get out of the car, they're having trouble going around the shops. They're having to lean on a trolley. And so already their lifestyle is changing and is becoming less pleasant for them. So it's little pointers like that, difficulty going upstairs, only going up one at a time, not feeling confident on the stairs, having a disturbed night's sleep, having difficulty getting out of bed because your knee's so stiff. So you can still walk and you can still get about, but the quality of your life has gone down, and what we call your activity envelope has got very small indeed. And so it can often creep up on you quite slowly, but it's worthwhile thinking if you're turning down invitations to go out with friends because you can't get there, or you don't like sitting in a restaurant because you can't get up afterwards. That's the sort of time when you ought to be speaking to your surgeon and say, look, I am having some difficulty here. What do you think?
Okay. Interesting. That seems a good overview of the current situation. Now, so let's assume then that we've made the decision to go ahead with surgery, and now we're moving into by no means all, but some of the commonly asked questions that sort of we've had said, and I've tried to organise them more or less chronologically. Now, a few of the questions in here are a little bit, anaesthetic, so let's not go into them into too much detail, but they do pop up a lot, So let's see how we go. Now, very common question: how long does the operation take? How long does a knee replacement take?
It's about as long as a piece of string, okay? Because there will be surgeons operate at different speeds. And people's cases are more or less complex. So the key thing is that as you have the surgery, you'll be looked after throughout. And there are some cases that I would do that would take 1.5 hours. There are other cases that might take me an hour. Knee surgery itself is not like some other surgeries that last for hours and hours and hours. So I think you'd be unlucky if anything lasted more than 2 hours. But usually knee replacement, partial resurfacing would be an hour, an hour and a half. And then there's a little bit of recovery time afterwards. So people are often away from their hospital bed for much longer than the surgery takes. So it's often 2.5 hours away from your room.
Okay, yeah. And then I guess a related question then, and this is where we get a little bit anesthetic, so we're doing very high level stuff here, but what do you say to patients who ask about whether will they be fully asleep? Will they have a general anesthetic? What are the common options there?
That's really interesting. Now, and patients are sometimes afraid to ask because they think the surgeon has a definite view and all patients should go to sleep, or all patients should stay awake and have a spinal anesthesia. That's where there's a little injection into the base of the spine that will anesthetize the body below the waist. So in both methods, of course, you don't feel anything, which is important. And what happens is that the patients may ask, well, which is the safest? And the answer is, quite recently, there's been some data to show there's no difference between the two techniques of going to sleep or remaining awake and having a spinal anesthesia in terms of safety. So there are some advantages to either side, and it depends on the individual patients which that advantage will be. But it's certainly worth discussing with the anaesthetist, who always sees the patient before the surgery, which would be the best for them. So there are some patients who are particularly suited to a spinal anesthetic where you remain awake and just have your legs anesthetized. Now, you don't have to be awake because you may not want to listen to the jokes that the surgeons are saying. So you can have a sedative, so you'll be naturally asleep during the operation, but of course your legs will be anesthetized. And then there are some patients who are much better treated with a general anesthetic, so we can control the breathing and everything. And the anesthetist will say, look, for you, a general anesthetic would be best. So it's worth an open discussion with the anesthetist, and most surgeons now won't have a problem with either type of anesthetic. So it's a free choice.
Okay, that sounds encouraging. So we've spoken a bit about the decision to have the operation. We've touched on the anesthetic options. Now, for someone who's then in the position of getting ready, and the operation is a couple of weeks or perhaps even a few days away, what are your sort of top tips to help that person get into the right mindset and to prepare their body, and perhaps at home as well?
Sure, that's a great question, because I think a lot of people feel that once they've decided for surgery, there has to be something they have to do to prepare for it, and there is no doubt that sort of getting fit for surgery, which is a phrase that people often use, is a good idea. But what I would hesitate people to do is, once we've decided they've got a really bad knee that either needs some form of resurfacing or partial resurfacing, is to start trying to jog or to go to the gym or to get fit in those 2 weeks before the operation. What they can do is spend a lot of time getting their knee particularly sore by doing a lot more on it. So when they come to my surgery, their knee's red and inflamed, and actually the surgery is actually a little more uncomfortable for them because they've got their knee so inflamed. So a long time out from surgery, it's worth looking at your diet, it's worth looking at how you live your life and getting enough sleep and being prepared and relaxed. Running up to 2 weeks before the surgery, there's a lot of work that we've done that suggests that almost looking forward to the surgery and having a positive mental attitude, that this is something not to be worried about, it's something to look forward to, because this is where we're going to get you better, we're going to get you more active, going to get rid of the pain, it's a safe procedure, and you need it. So that positive mental attitude we can show makes a big difference to how patients recover. Where if you have the wrong or slightly negative attitude, you can slow your recovery because you're apprehensive or over anxious. So when you have your surgery, you'll come to pre-assessment. It's a great time to ask the questions of the nurse and to make sure you're fully informed. And a lot of surgeons will send a lot of detail about the operation that you should read. It's not scary, and there's lots of stuff that's available on my website about the different aspects of knee surgery and how you can prepare.
Yeah, absolutely.
So I think being informed and prepared is better than hitting the gym.
Yeah, okay. So as ever, I guess it's about finding a balance.
Yeah, I think so. Yeah.
But you raised a really interesting point there around the positive mental attitude and sort of positive visualization, positive goal setting. It's really fascinating how much of a difference that can make. And I think it's something that we're seeing increasingly in research, and indeed in your versions of the myrecovery app, where we've added some of these elements. We're getting fantastic feedback on people finding that really helpful, both before.
That's true. That's absolutely true. When we've been working with Mary Zanutto, who's a sports psychologist, in her work in showing how a positive mental attitude really makes a difference to how the patients achieve afterwards, not just in level of exercise, but how they feel about their operation, amounts of painkiller they use, and how active they are afterwards. So I think that's really, really important. And as I say, that stuff is available on my website, but I'm sure other surgeons have their little tweaks as well. But I think if patients realize that's how we're looking at the operation now, and perhaps not just in knee surgery, but in other forms of surgery, if we're prepared and anticipating things and almost looking forward to it, we can make a huge difference to how we recover and how quickly we recover.
Yeah, absolutely. And I think it's just increasingly recognizing that we're further on this trajectory where the people having the operations are increasingly part of the team and involved in the decision making and in the recovery and in the goal setting and so on. The operation itself just being one part of a wider process.
That's right. So it's a part of a process, and that process really starts when you first see your surgeon to when you say goodbye to him afterwards, and it involves everyone who's just as important as the surgeon, the physiotherapists, the nurses, the rehabilitation specialists, the pre-assessment nurses, the theatre team. So we try and work it as if you like a journey, and it's not just the operation. So I think it's a great point to make, and that's true of pretty much everything that involves hospital and operations.
Yeah, no, indeed. And of course, you've mentioned your website. We'll make sure there will be links below this video to your website and indeed also to Mary Zanutto's website, the sports psychologist, where people can find more.
Perfect. And I think that'd be useful links to have if that helps.
Yeah, absolutely. Now, and you spoke of the journey. Now, if we rewind that journey just a little bit, and we've covered some of the stages of getting ready for surgery. Now, what sort of things would you generally say to your patients who are asking about what to expect after surgery?
Sure. I think I would say the thing to expect is to get better. And I think that a lot of people do have a kind of concern, and sometimes it's their friends who tell them how awful it's going to be. The answer is it's not awful. And if you're visiting a specialist knee surgeon, they will have taken particular care to make sure that your post-operative journey is very smooth, because that's what we want to see. So if we were talking about someone who had a partial knee resurfacing, or if you like a total, then on the day of operation, we'd like them to get out of bed, and they can be fully weight bearing. We'll make sure they don't have pain. We can offer them pain control. And so walking is possible. People often worry about, well, how do I go to the loo after an operation? Well, the answer is that it won't be any difficulty with the bed or anything. We'll actually say to you, if you want to get up, we can take a few steps out to the loo and everything can happen normally. And so it's not an awful procedure. Expect to get out of bed. There's no special position in bed. We're quite happy for you to move around as much as possible nowadays. So you can lie on your side, you don't have to lie on your back. And so usually most surgeons will need a couple of days with their patients afterwards. And whilst they're in hospital, as well as regular analgesia, the physios will be visiting, they'll be encouraged to get out and walk about. We'd like to have them doing stairs before they went home. So usually most surgeons will have sort of a magic rule of 3 in order to let their patients escape from hospital. First thing is they've got to be able to walk. They've got to be able to do stairs. And they've got to have a dry wound. That means that where we made the incision, we want it to be nice and dry, so it's safe to let the patient home. And usually once we've done those three, patient can go home, and they're usually self-caring at home. So in the old days, people used to worry about bringing the bed downstairs and sleeping downstairs for 6 weeks. Actually, we like patients going upstairs because it's quite good physiotherapy. So no particular changes at home. So it makes it a lot more simple.
Well, you're preempting a lot of the top questions, so that's excellent. Now, on that though, around the level of independence after surgery, we've had a couple of questions coming from people who live alone normally, and they're wondering, should they find a family member or friend to come stay with them sometime? Will they? How much support should they expect to need in the general sense?
Sure. So it is always great, maybe for the first couple of nights, to have someone around with you at home. And so although technically you're self-caring, which means you can get up and you can take yourself to the loo and you can go up and downstairs, it's early days yet. And you'll be able to do those things. But it's nice to have a relative or a friend who's either nearby or perhaps sleeping in or popping in the evening and then first thing in the morning, just to make sure you're okay for maybe those first 2 or 3 days. So if you had the surgery on Monday and went home on Wednesday, it would be nice to have someone popping in Wednesday and Thursday nights and then Friday, just to see how you are. And by that time, by the weekend, you'd be probably happy to sort of potter around your own house and look after yourself. So it's not obligatory to book yourself into a nursing home for 2 weeks afterwards, but it's just great to have someone popping around. And perhaps the great thing would be have them stay overnight just for a couple of nights when you went home.
Okay. Well, that also sounds quite hopeful and encouraging. In terms of supporting people's independence after surgery, though, have you found that there are any particular gadgets or equipment that your patients find helpful or useful, or that they would?
So oftentimes as part of surgery, you'll have a pre-assessment and they'll look at your, if you like, your needs at that time. And there are some people who have very small houses with windy stairs that might need some help going upstairs, or they might have low loos and you might have to have a raised loo seat to prevent you sitting down too low. So it's great to be able to discuss those needs when you have your pre-assessment, and they can arrange that those aids, if you like, are available for when you go home. But to be honest, most people probably won't need anything at all. The hospital will send them home with 2 crutches, which are just really for your balance and stability. Understandably, your confidence won't be great when you go home. And so just having a couple of crutches to lean on for your balance really is a great idea. And when people start going out and walking more outside the house, they like the crutches as a kind of stability thing. It also keeps people away from you so you don't get run over by people, which is quite useful if you've just had knee surgery. So really, when you go home from hospital, you certainly have a couple of crutches. Their use is up to you, and you'll find that most people forget their crutch when they want to go out, when their knee is strong enough to look after themselves.
Okay, well, good stuff. And so you've mentioned the crutches and getting out and walking and going up the stairs being a form of physiotherapy that can be good to do after surgery. What would be your general recommendations in terms of activity after surgery, and how quickly should one sort of aim to progress?
That's right. And so that is again another change from, if you like, how it used to be. So how it used to be, we used to have a menu and everyone had to do these 20 exercises by 2 o'clock, and then they had to do another exercise. And if they didn't do it, they'd kind of fallen behind, and the physiotherapy would be angry and upset and say they're not trying hard enough. And what we've realized is that, surprise, surprise, everyone is individual. And some people will progress quite quickly and easily, and other people might struggle a little bit, but then catch up the other guys afterwards. The quicker guys may actually slow up at about 6 weeks. So what we say to people now is listen to your knee. Okay, if your knee is hot, swollen and painful, that day, limit your activity. Don't push yourself too hard. You're only going to make it worse. Because you've rested, the next day will be better. Your knee will be less swollen, less painful, less hot, and you can actually do more. And that's where, if you like, I found the app really useful. So the app that we use with our patients, myrecovery app, is actually really good for that, because people can check in and look at the exercises they do that day, record what they do. Let's say they have a slow day. but they can see that. And the next day when they're feeling better, they can think, oh, I can do a bit more. And they can answer it, they can enter it on their app, and they can see how their progress is going. So it's all individual. Listen to your knee, and the app is a great tool because obviously it has physiotherapy on it as well.
Yeah. Well, yeah. Always great to hear about the app, but I think the real take home there is listen to your knee.
That's right. Yes.
And I guess also, you know, as I've raised in this video and in every other, listen to your surgeon as well and your individual plan.
That's quite right, because surgeons spend a lot of time trying to get this right. And although I will say what I prefer to do, other surgeons will use different implants and they may have different advice. So don't be too upset if your personal surgeon says, no, we won't do that because I'm using something different to Barrett, and so I want you to do this different thing. So as I say, that's a great little caveat to put in there, Axel. Your own surgeon will know what he's done or she's done, so it's easier for them to tell you, but it's a general what I do thing.
Yeah. Well, fantastic. Well, Prof, thank you so much for joining us for this masterclass. I think it's been a really lovely wander through your experience over the years, and I really think people will find it helpful. Of course, you know, do comment below and keep sending in any questions, and we'll dig into them in another episode. Is there anything you would like to say to sort of sign off this session, so to speak?
I think it's sometimes the thing I have from patients is that they find it confusing to know who to go and see. And they know, how do we tell someone's good? How do we know who to go and see with their knee problems? And I think perhaps my own advice is that because knee surgery has become a lot more technical recently, I would say make sure or try and visit a knee specialist. So you can look up everyone now who works in the NHS, who works privately, and you can see the sort of work they would do. And it's obviously easier to go and see someone who is habitually doing a lot of knee surgery than someone who did a knee operation last year. And so I would say that if patients are interested in finding a knee specialist, have a look on Google. We often don't say that because you shouldn't self-diagnose, but you'll find the surgeon you're looking for. And what you want to do is make sure that he or she has a recognized practice in knee surgery and is doing a large number of knee procedures, which means that when you come along, it'll be like a walk in the park. It's something they're doing all the time. And as I say, that's the only reflection of knee surgery becoming a little more technical. It's best to go and see someone who's doing it all the time.
Yeah, interesting. And I think that takes us kind of full circle, because we started by talking about all the technical advances that have occurred in recent decades that have made it, you know, an easier procedure, so to speak, for patients, a lighter procedure, less invasive, fewer days in hospital, and so on. But then on the other side of that, indeed, it is now more specialized and more technical. So I think it kind of, we've reached the other end of the rainbow, so to speak.
It's a perfect circle, Axel.
Yeah. Excellent. Fantastic. Well, thank you to everyone for watching and for sending in the questions. Thank you very much, Prof. Yeah, that's it. Have a great day, everyone. Take care now. Bye-bye.